These next two talks I'm going to give are in contrast to what I normally talk about, showing surgery and surgical videos. I'm going to step away from that and think about strategies that we're using that are an important part of our surgery, but not necessarily the surgical techniques. Let me start by talking about shoulder replacement surgery. It is a fantastic surgery. It makes a significant difference in people's lives. It changes their day-to-day activity. It changes the way they can eat, wash their faces, take care of themselves, and function and be active. Nonetheless, infection can occur, and an infection is a relatively devastating event. The rate of infection, fortunately, is very low, and our published rates of infection here are even lower than the national averages, but it's about 1% for someone who's never had any kind of surgery after shoulder replacement. When you go up to revision, it gets higher. When we look at reverse shoulder replacement, these are often patients who've had multiple surgeries before, or they get the reverse, so it gets a little bit higher. Men and younger men seem to be the highest risk population for this. If you've had a previous trauma or you develop some postoperative bleeding, those two are significant issues. But what really happens and where our healthcare is changing is that we're going to look at the cost of an episode of care. And institutions that can deliver care at lower cost with better outcomes are going to be the ones who are favored, who are allowed to do more procedures, and actually are going to get paid for these procedures. We look at an infection. An infection can triple the cost of that single episode of care. So suddenly we've gone from a very valuable, life-changing procedure to what can be a devastating concept and an extremely expensive burden on our healthcare system. So what can we do to try and improve that? Well, I think we have to understand why infections get caused and where they come from. Typically, all of us in this room would say, oh gosh, yes, infections, staph, strep, those are the major guys. We all know about them. We've seemed to get a lot better in shoulder surgery. We've gotten rid of most of this, not all, but most of the staph and strep. And the pathogen that we now really chase down is P. acnes, Propionibacter acnes. That's the same bacteria that lives on our face. It's the same bacteria that troubled me when I was a teenager with pimples, and it seems to live on our face and upper torso. And as we look at the shoulder world, the majority of infections in shoulder surgery are coming from this one specific organism. It can be hard, unlike other infections where a patient will come in with a red wound and purulence, and it's clearly infected, or even when you go in to make the incision to clean it out, you can tell it's infected. With P. acnes, you can't tell. It's very challenging. So unlike this case that got sent in to us, where it was very clear that this shoulder replacement was infected, the traditional diagnosis of shoulder infection after either arthroscopic or open surgery is very hard. It's pain. Pain is the major complaint. And we try and figure out, is the pain new, or is it since the surgery, or is it something that developed? Did something happen? Did you have dental work? Dental work is a very scary thing in the perioperative period. Was there another infection? Did you have a hand infection or a foot infection? Or do you have any special risk factors? These are the things we are always worrying about. Imaging, well, I try and look, and the clinical signs may be very subtle. Of course, some draining from the sinus. Of course, if you have fever or erythema, but these are not really the typical, the present, or the norm. The x-rays, every once in a while, I can see the bone changing, the prosthesis loosening, but not always. And MRI and bone scan are not that helpful for us. So far I'm giving us nothing. I'm saying you really have to go with your gut. So what about labs? Labs are great. Did we send labs? Well, of course. And if we look at routine labs, ESR, white blood cells, if they are normal, it's non-diagnostic. So you can have normal labs in an infected shoulder replacement, which is really, again, very challenging. In the setting where the labs are abnormal, it's very helpful because that really will steer you down the pathway. I've got another problem here. I've got to really take care of it. There are a couple of other new labs that exist, one called Alpha Defense and the other one IL-6. These are expensive labs, and we don't fully understand and know the efficacy of these labs helping us to diagnose infection. So it continues to go nowhere. So what I can tell you about detection of infection is that normal serology, normal blood work, does not exclude it. Sometimes we'll aspirate the joint, we'll send them down to the radiologist, where they'll put fluid in the joint. That too is ridden with false positives and false negatives. And it may be that we have to go to an intermediary step where we arthroscopically take some biopsies and test you for infection, then bring you back at a later point for diagnostic surgery. But once again, that's another surgical procedure that this patient has to go through and makes for a very complex conundrum. I think this will be the interesting part, and this part actually is a series of 2 studies that we did here at this hospital, and many of you in this room participated in these studies, and you'll remember the 12 and 13 cultures I took on certain patients in the microbiology lab. Really had to do a lot. When we talk about how we currently prep skin, there's betadine, DuraPrep, and ChloroPrep. And each of these 3 preps, there may be 1 or 2 surgeons who use some outside nuance things, but this is probably the meat or all of what we're going to use. And in orthopedics, we like to use ChloroPrep a lot. And why do we use it? Well, there was one big study that really encouraged all of us. And a group in Chicago looked at 150 patients undergoing surgery, and they said, okay, well, how often does this skin prep eliminate the bacteria? And as it turns out that after you prep the skin with betadine, 31% of patients still had bacteria on their skin. After you prepped it with DuraPrep, 19%. And after you prepped it with ChloroPrep, it was down to 7%. So, that was very compelling data for all of us to switch over. And this is something we've been doing here for, I don't know, at least 7 or 8 years. Interestingly, as you look more carefully at this data, none of these preps were any more or less efficient in getting rid of the P. acnes, the problem I have on the shoulder. So the prep really wasn't perfect. So we wanted to study this a little bit more. And there was another author who came out with a study and said, look, we think that P. acnes lives in the shoulder joint, and we think it's like Helicobacter, which caused peptic ulcer disease, and this could have been a big epiphany. We didn't really believe that. So what we did is we set out to figure out how often this bacteria is on our skin, what happens, and how effective is a surgical prep. So we looked at 57 patients, and 57 patients underwent arthroscopic surgery. These were patients who never had any surgery before. And we took 7 cultures per patient. And for those of you who work in the OR, Paul Jablonski, for example, 7 is a lot of cultures to take. And they all have to get down separately, and they all have to be held for 14 days for P. acnes. So it's a lot of work from everyone in the room standpoint. And we looked at these cultures, and what did we find? Well, after we took the cultures, they went downstairs and went through a very comprehensive microbiological procedure. And anyone who's really interested in the micro, I can sit down with you and go through the slide with you. Let me tell you, Dr. Sabet and I probably spent 2 or 3 weeks arguing about each nuance of each step until we finally figured out how to best identify this bacteria. But what did we find? And I think this is all interesting. A culture where I took it out, I took the swab in air for 5 seconds and put it right back in. So it wasn't handed to me open. It literally had 5 seconds in the air, had a 5% chance of coming back as a positive for P. acnes. So there's a false positive rate. Once I swabbed the skin, 15.8%. So that means 16% of our patients who were prepping, and we're prepping them, we're scrubbing them with a brush, we're patting them dry, and we're using 2 or 3 ChloroPreps, still 15.8% had bacteria on their skin. As you took fluid aspirate or you took samples of tissue, it was up to 20%. And by the end of the surgery, and these are about 1 hour, these arthroscopies, 40% of patients had bacteria on their skin. So automatically I'm questioning, how well is this prep or any prep working? When we break it down and look specifically at men, and men seem to have a higher burden of this bacteria living on their bodies, we have more hair follicles. We went to 63% of men at the end of a 1 hour arthroscopy had this bacteria on their skin. That's a really scary thought. So these patients aren't necessarily getting infected, but this is their chance. This is the moment where they're going to get inoculated from the surgery, and this is the risk factor. So we realized that, and our conclusion, and we published this and presented it all around the country, is that the dermis, our skin, is not adequately sterilized by our current prep. If we think about where this bacteria lives, it lives in our sebaceous glands. It lives deep down below the skin. It's very hard for a surgical skin prep to penetrate the dermis in a 1 or 5 minute scrub process. It just doesn't happen. It needs to get better. So that's what we did. We said, look, how can we get this better? So we teamed up with microbiology and orthopedics once again, and we said, look, let's think of another way to address this. And we were really scratching our heads, and we were thinking about different antibiotics and different ways to do this. And someone said, well, what do the kids use to prevent their acne on their face? And you know what they use? They use Clearasil, right? They use benzoyl peroxide. So we reached across the counter and said, well, maybe we can try using this idea. So we took another 50 patients, And based on the dermatologic literature, we wanted them to start applying this before surgery. Well, we wanted enough doses to get in, we wanted this to penetrate the dermis, and once we penetrated the dermis, then we could see if we got a better kill rate of this bacteria. They underwent the same standard preparation in the operating room, and this time, 6 or 7 cultures weren't enough, so we went up to 13. Which really drove a lot of people very crazy. 13 cultures. So we had a total of, for this one, 650 cultures, a lot of forms to have filled out. And this is the important slide. And there's 2 ways to sort of describe it. One, we want to see a statistical difference between certain numbers. So the difference between the number 4, 6, 2, and 10, are they really different when we manipulate this with statistics? So no, actually, once we used the benzoyl peroxide, there was no difference in the rate of a positive culture from just a skin swab in the air to what we took off the skin, to what we took in the tissue, to what we took at the end. It was somewhere between 4 and 10%, and none of those numbers were really different. So what that means is that this actually worked. We were able to get it down to just about the level of control. Now, when we compare it to our study just before, our air swab was 4% or 5%, so our risk of a false positive stayed pretty consistent. The joint fluid, 4% versus 17.5%. We cut it in a quarter. And most important, the skin at the end of the procedure. We were 10% with the benzoyl peroxide group, 40% without it. So substantial reduction with something as simple as benzoyl peroxide. So adding this 5% benzoyl peroxide to current skin prep can reduce the rate at which we find this bacteria. And we found no significant difference in any of the cultures that we took. Unlike the study before, where aspirate was 17.5%, tissue cultures 22 to 32%, and 63% of males, we were down to 10%. So for $8.75, and I think you could get it down lower, but something with Amazon shipping to the office, we had to go straight. But for $8.75, we looked at a value proposition here, and this is a normal part of our practice. So here's what we know about this currently. Positive biopsy or positive cultures are introduced into the surgical field by inadequate prep. The yield of putting a needle into the shoulder and aspirating it is very questionable at best. If you obtain cultures, remember, that one culture has a high risk of coming back as positive, a false positive. So again, when I take 3 and 4 and 5 cultures, it's not that I'm difficult for that reason, maybe different reasons, but it's because I don't want to find myself faced with having taken one culture just to be careful and finding it to be positive. And then what do? Do I subject that person to 6 weeks of IV antibiotics? It's very slippery. And surgical skin preparation needs improvement. So currently, what are we doing? We're looking at benzoyl peroxide. We use chlorhexidine the night before. We use impregnated drapes. We use clindamycin and Kefsol both. We use a betadine lavage where we irrigate the wound out with betadine, and we're using vancomycin powder at the end of our surgery. And this is really helping us to shine out and have lower rates of infection in this country. Lastly, I think this is hard business, and we can't prevent all infections. So I keep this guy in my locker, and I try and make sure we don't get into trouble. So thank you for that talk.